Okay, so this is the case presentation for Mr. BN. Okay. So this is the case presentation for Mr. BN. He was admitted on the 20th of October and he spent about 9 days on admission. He's a 28-year-old male who presented, he's a footballer. He presented after being referred from a referral facility on account of thigh pain of 4 weeks duration. The thigh pain was said to be gradual in onset, aggravated while walking and relieved by rest. There was no associated limb stiffness. There was no discoloration, no ulcer, no history of trauma to the limb, and he was not a known diabetic, hypertensive, and there was no history of dyslipidemia. So he presented with a lower limb Doppler, which was done at the referral facility, which suggested occlusion present in the deep femoral artery, about 4 centimeters distal to the bifurcation. On examination, he was not in any distress, not pale, anicteric, afebrile, and there was no pedal edema. His RBS on presentation was about 5. Pulse was 64 beats per minute. BP was fine. JVP was not raised. His apex was at the 6th left intercostal space and anterior axillary line, and his first and second heart sounds were heard. On musculoskeletal exam, there were no ulcers. His limbs were not shiny. There was no area of tenderness over his limbs. His right femoral, popliteal, and dorsalis pedis pulses were present and full. However, his left femoral, popliteal, and dorsalis pedis pulses were present, but they were reduced. Other examinations were essentially normal, and we made an assessment of left lower limb peripheral artery disease with unknown risk factors. So I just want to ask the audience, which risk factors do we feel like were not present in this patient and would have been present or is typically present in peripheral artery disease? Anybody? Okay, we have someone there. Please, can we help out with the mic?
Hypertension, diabetes, history of smoking, sedentary lifestyle.
Exactly. Please, can we give her a round of applause? Okay, thank you. Okay, so moving on, we did some baseline investigations, which were all essentially normal. Triple cellularity normal. His pulmonary echo showed good heart function, good systolic function in both ventricles. There were no clots seen at all. This was his ECG done at presentation, which showed a normal sinus rhythm. His heart rate was about 75 beats per minute. It was essentially normal. So he was admitted, he was commenced on antiplatelets and anticoagulants, and he was counseled for peripheral angiography. So this is a video of the peripheral angio done. Play the video. Okay, so this shows when the dye was inserted, we can see that there was no flow in the artery. So this is, okay, this is the same video, sorry. Okay, this next video.
All right, let me help you,
Okay.
because you are stammering. All right, so does this work? Okay, good. All right, so can you play the video for me? Okay, I forgot to make it. Okay, so normally they should have been, this is the main common femoral, those that can remember anatomy. And deep femoral should have come like that. It's supposed to come all the way down. We can see some dye All these black things where the fluid, where the contrast is going into the vessel, and we are not seeing much of that flow. Okay, so I'll just go next. In this one, what is happening here? This is a catheter. We go in from the other femorals, we go to the common iliac, turn the catheter around down into the leg. Now we've taken the catheter past the blockage, then we've passed our wire way down into the thigh, past the blockage. So I don't know if that can play. Can somebody play that for me? All right, so the wire is down, cross. Can you see the wire that is bent and looped down, and you can see it moving down? So normally, so the wire is now crossing, crossing, crossing. So go to the next slide. Can you play this one? Now we have seen the wire. Okay, just similarly. There's a blockage there. That's why the wire had to turn and loop before it can cross whatever the blockage is. Sometimes if it is just atherosclerosis or some narrowing, we just put a balloon and a stent. Okay, go to the next slide. Next slide. Okay, I'm the one supposed to control it, Abby. Okay, so wire has gone through. We have some flow. Remember, there was no flow in the leg, Abby. Can we press play, please? Go back. Press play, please. So can we see flow going all the way down? But there is still blockage, multiple levels. There is clot here that is not allowing to flow very well. There is clot here all the way down. Okay, so in that case, where you have multiple clots, if this person had come between 6-12 hours, you can take it out. But at this time, almost 1-2 weeks, the clots will have formed and organized. So you cannot take it out from through the catheter.
So the peripheral angio was done and it was well tolerated. It showed multi-level occlusion of the deep femoral artery with heavy clot blooding. Examination, vascular examination, his leg was still poikilotemic with no hyperpigmentation. The pulses were still not palpable. However, his fine touch sensation was intact. Power was 5/5, and the right lower limb was still essentially normal. So the guest was placed on dual antiplatelet therapy and commenced on unfractionated heparin, and he was counseled for a left femoral artery embolectomy. So the guest had, on day 3, the guest had the left femoral artery embolectomy, and the procedure was well tolerated. The findings were a 6 centimeter circumferential organized plaque in the distal left deep femoral artery, and the arterial wall showed no evidence of atherosclerosis. So after the procedure, we checked for the pulses. They were now palpably strong bilaterally. His left foot was now very warm and pink, and his SpO2 was good. The left wound dressing was clean and dry, and it was a satisfactory post-op state, so it was a successful procedure. We continued his anticoagulation, and we monitored his ACT. He was for a CT peripheral angiography after the procedure. He continued his antibiotics and his analgesics. So the peripheral CT was done, and we visualized his arteries, which were very clean. There was no stenosis, there was no thrombus seen, there was no extravasation of contrast seen, and it was a normal peripheral angio. So this is just a picture showing the complete blood flow. There are no more occlusions in his femoral arteries. We also did a repeat lower limb Doppler. It was a normal vascular study, no evidence of DVT done. So on day 78, there was no pain in the lower limb. All his pulses were present, all his peripheral pulses were present, and however, there was localized swelling of the penile shaft noticed. However, there was satisfactory perfusion of the lower limbs as the assessment. The plan was to discontinue the subcutaneous anticoagulant and to commence on DOACs. We also wanted to do a PCV. His PCV was 30%. On examination, he was not in any distress. He was not pale, anicteric, acyanosed, or dehydrated, no pedal edema. His cardiovascular exam was essentially normal. His abdominal exam was essentially normal as well. The musculoskeletal exam showed a resolving thigh swelling, and the penile and scrotal swelling was also resolving. His pulses were present and clean. So his respiratory exam was essentially normal as well, and an assessment of satisfactory post-op state was made. The guest was subsequently discharged and asked to come in for alternate wound dressing. He was discharged on antibiotics, hymatinics, and anticoagulants for 1 month. He was to be seen in the clinic in 1 week. So on follow-up, he was seen. He had no complaints. He was no longer in any pain. He was commenced, or his DOAC prescription was continued, and we counseled him on thrombophilia screening later. Thank you.